I don't have an initial slide. I'm just going to jump right in. So this is a quote from Burroughs Wellcome and Company, actually by H.S. Wellcome from 1911. And of course, this is a pharmaceutical company from the UK, but they were the first to make insulin. And H.S. Wellcome said, "There is perhaps no excretion of the human body which possesses more interest to the medical practitioner, and probably none which throws so strong a light on the organic processes of the disease as well as the healthy body as the urine." And I really like this quote. I've always been a big fan of the urine. It's my favorite body fluid, but my favorite urine quote, dear, is this one by my mentor, Pat Fleet, who said, "The urine never lies." Pat Fleet was at Harborview for more than 35 years, and he said this in the circa 20th century timeframe. And I've always believed this to be true. This is a picture that I recently took from our brand new microscope, which has phase contrast and other pretty things. And I would ask the fellows if I were giving a talk in person what this was. But I will tell you that these are struvite or coffin-shaped crystals in someone with a Proteus infection and staghorn calculi. So let's go through just a brief history of the urinalysis. So as early as 4000 BC, Babylonian physicians were actually examining urine colors and imparting all kinds of important conditions to them. It wasn't until Hippocrates in 460 to 322 BC who first noticed that bubbles actually represented proteinuria in the urine. And then Galen himself was the first to recognize that urine was actually a filtrate of blood. The first treatise on urinalysis was made by Theophilus Protospatharos in 700 AD, and it was called De Urinis. And it was the examination of urine at that point was called uroscopy. Ismail of Jujani in 1041 recommended that it was best to get a 24-hour urine collection. And what followed during the Middle Ages and into the early Renaissance was a period of what's called uromancy, where all kinds of romantic virtues were imparted to the urine. And cooler heads did not prevail until later into the 1600s, when Frederick Deckers described albumin in the urine for the first time, after which we see some of our old friends, Richard Bright, after which IgA nephropathy is named, and of course, Henry Benz-Jones, who we know well. A picture of Hippocrates instructing students in what was called the judgment of disease from the urine. And a lot of emphasis was placed on this, this vial, which was called the matula, under which urine separated into different layers, and different layers were ascribed different importance in disease states, and a very complex wheel recognizing all the things that could be discerned from the color and the look of the urine. Finally, H.S. Wellcome's book on the evolution of the urinalysis contains these beautiful outlines of colors of the urine and what they mean by Fletcher from 1600. My favorite is number 5, and we'll read, "The perfect and absolute best, partly saffron, lighter than crown gold, and yellow as pure gold." I hope one day my urine and yours will look like that. More often we see things like crimson, like blackish red wine. And perhaps oily green. Not sure what that was about. All right, so fast forward to the 20th century when Helen and Alfred Free developed the first urine test for glucosuria, otherwise known as clinostix. And then in 1969, a woman, Margaret Crane, designed the first home pregnancy test. It hit the market in the 1970s, and there were actually concerns that women would not be able to figure out how to use it. And those were rapidly put to rest. Women used it just fine. So here are my own questions for the urine today. The first is, who's better at analyzing the urine sediment? Is it nephrologists or is it the machines that are currently active in our lab? Next is, when we see cells in the urine, are they dead or are they alive? And is there a way to tell? Probably the biggest thing that I've been fighting with is the question of whether you can find podocytes in the urine sediment. And if you can, what does it mean? I've been looking for podocytes for many years. Then we'll jump from from bench more to bedside and address some questions that you probably know the answer to, which is first, do you need to have pyuria to have a diagnosis of AIN? Does the number of granular casts help you discern whether you'll need dialysis or how you'll do clinically? If we see crystals in the lab, does that mean our patient's going to get a kidney stone? And finally, if we have time, I would love to know your questions for the urine. So let's jump right in and ask who's better at analyzing the urine sediment. So to answer this question, I had to go on a field trip. So I went down to our lab to figure out exactly how urinalyses are done. And the workhorse of urinalysis is ironically this machine called the IQ 200 Elite. It can handle many, many specimens at once. And when I spoke to our head of chemistry, she told me that the IQ 100 uses digital flow morphology technology and auto particle recognition software. So it actually contains a microscope that takes 500 digital images as particles in the urine travel through a flow cell. The images are then sorted by a large neural network that contains up to 26,000 reference images. And then those particles are classified into 12 different categories. And this is true of most of these lab urine machines, that the things that they're taught to recognize are red cells, white cell clumps, squamous epithelial cells, non-squamous epithelial cells, hyaline cast bacteria, sperm mucus, unclassified crystal, and yeast. Well, Lisa Yannick-Lawrence, who's the manager of the UW chemistry lab, then told me that despite their claim of distinguishing 12 elements in urine, we have low confidence in what it does. In my opinion, the image quality is poor. With 1.2 pixel, it really doesn't distinguish simple red cells from yeast, from calcium oxalate crystal, or from artifacts, amorphous phosphate crystals from bacteria, etc. Due to its poor image quality, we do manual microscope checking about half the time. So not a lot of endorsement for our lab machine for urinalysis. I then asked one of the techs to show me exactly how the pictures come out that he looks like. I asked him to pull a calcium oxalate crystal report that he had recently seen. And so all of these things were recognized as calcium oxalate crystals. Only perhaps one really looks like one. Others could be, in my opinion, anything from air bubbles to red cells to random particle. This probably looks like one too, dihydrate. I asked him to show me some casts. He pulled up this and informed me that the machine reads this as a hyaline cast. And when I told him it looked granular to me, he told me the granular ones are usually darker. And yet it still looked like a granular cast to me. When I asked him what his threshold was for actually looking at the urine himself or whether there were rules for it, it seemed very tech dependent. He said he only looked if there was a disconnect between what was on the dipstick and what was actually reported by the machine. Okay, so who's better at urine analysis, nephrologist versus a lab? And this is absolutely my favorite study out of UC Davis from 2005 in AJKD. And what they did, it was a small study, but still a lot of fun. They got the consult service together and they looked at 26 patients on the consult service for which urine was really important in making the diagnosis. And this was the original diagnosis of the consult service, lots of ATN, some GN, and then the simplified diagnosis when serologies were back and things became more clear. And what they did was they took an experienced nephrologist named Nephrologist A, and Nephrologist A didn't know anything about the patient. They just said, look at the urine and make a diagnosis. So Nephrologist A, all he did was look at the UA, and there was really surprising consistency with what the clinical team thought, so purely on the basis of the urinalysis. They then asked nephrologist B, who was another experienced nephrologist, to try to make a diagnosis based on what the lab had reported. And you can see that nephrologist B had quite a lot of challenges. So in at least half the settings, he was unable to make a diagnosis at all based on the lab report. And in some of the other, his diagnosis was not quite concordant with the team. They then asked nephrologist B to take a look at the report by nephrologist A, and in that case, there was more concordance. And finally, nephrologist A, who'd only been able to look at the urine at the beginning, was asked to look at the lab diagnosis, and again, was not able to make a diagnosis a fair amount of the time. Just to simplify things, the accuracy of diagnosis compare with the consult service. When nephrologist A just looked at the sediment, look how often he made the appropriate diagnosis. So almost all the time just by looking at the urine. Whereas when nephrologist B was only allowed to look at the lab UA, he made the diagnosis only 5 out of 26 times. One thing that was noted when they went through these samples was that the lab UA very frequently missed renal tubular epithelial cells, very frequently missed granular CAS, and also renal tubular epithelial cell CAS. The other important point in this series was that nephrologist A identified all 5 cases of glomerulonephritis properly by noting dysmorphic red cells, but the lab missed all cases of dysmorphic red cells. And in all my years at Harborview, I've seen the lab call dysmorphic red cells once ever. This is a paper from Lab Medicine in 2021, where they looked at 103 patients with AKI versus controls. And you can see there's absolutely zero concordance between the times when the casts are seen by the automated machine versus when the casts are seen by the manual machine. That's pretty sad. And finally, just last year in Lab Medicine, there was a large paper comparing manual and automated urinalysis. And just to draw your attention here, the things that were really not good on the automated machines were the ability to classify crystals and casts, microbes, and lipids, which are all things I think arguably are very important for us to do well, whereas the manual person could do this on an excellent basis. The automated machine had very limited, possible but limited, or poor ability to do these. And so what that tells you is that the automated machine would never be able to pick out this beautiful oval fat body or be able to detect these beautiful fatty casts, or even make a proper diagnosis of struvite crystals, or even be able to tell that there was a red cell cast. So I think everyone knows, probably me being old, where I'm going with this. But the current urinalysis at Harborview and UW is done primarily by a computer, and likely many things are being missed. And there's a lot of concern that many nephrologists now forego urine analysis altogether. I've actually seen, probably fewer people doing urinalysis even on the consult service with time. And so I just want to point out how important urinalysis is. It's really an art, and it's the best way to see what's going on in the kidney. So let's go back to my questions from the urine. We'll come back to whether cells are dead or alive. My next question is whether you can find a podocyte in the urine, and if you can, what could it possibly mean? So as you know, we have a very podocyte-centric part of our division. Podocytes really have many roles. They regulate glomerular filtration. They're involved in synthesis and turnover.
Sarah, do you want me to be on the hot pager today?
Synthesis and
you were
turnover.
probably on the hot.
Yeah. They participate in local immunologic and inflammatory response, maintain morphology and integrity of the GBM, and produce paracrine factors such as VEGF. And we know that podocyte detachment is key to many diseases, and podocyte detachment and loss can be both acquired and genetic. The other thing that's very interesting is that if you look at animal models, podocyte loss into the urine actually precedes albuminuria. So seeing podocytes or podocyte protein in the urine may help us to recognize disease even before we see albuminuria. Here's a beautiful picture of a podocyte cell body with its large foot processes and interdigitating, smaller minor foot processes. I like to think that it's hugging the glomerular capillary loop and essentially retarding the passage of protein into the urine in a healthy state. So as I've been looking at urine over many years, and there were a few times that I showed Pat Fleet some cells, and he would say to me, do you think that could be a podocyte? I recently saw this guy. So podocytes in the urine are actually described often as binucleated cells, usually oval. And I wondered recently if that could be a podocyte. So in 2003, an often quoted article by Vogelman was the first to show that live podocytes could be detectable in the urine. He took 27 healthy adults, age 17 to 87. And then for some reason, he didn't have that wasn't a great control group because he otherwise used 14 kids with FSGS or lupus nephritis. He added a solution called propidium iodine, and propidium is helpful at distinguishing live from dead cells because it penetrates the nucleus and turns it red in dead cells, but cannot get into live cells. And then he spun the urine, put it on a slide, and stained it for podocyte markers. And at that point, podocalixin was a popular podocyte marker. And here's what he found. So this was a stain for cell nuclei in blue. And this was a podocalixin positive cell. It was binucleated and thought to represent a podocyte. On the bottom were propydian positive nuclei. So these represented dead cells, many of which were probably squamous epithelial cells. But you could see from the same picture that this podocyte truly looked alive. And I would argue that my cell kind of looked a lot like the podocyte he was describing. They kind of look like they're even looking at each other. So what did he found? Well, he found that in patients, he had 51 samples, and there were a mean of about 11 podocytes per milligram of creatinine. But with very active disease, one patient had 388 podocytes per milligram of creatinine, and almost all patients had at least one podocyte in their urine. Among controls who were adults without kidney disease, there were 40 samples. The median was 0 podocytes per milligrams of creatinine. Maximum was 5.3, and the range here was quite small. But almost half of normal controls had at least one positive urine for podocytes. Very sadly for me, podocytes were found to make up less than 1% of all nucleated cells, making it less and less likely that I would ever be able to find one in the urine. When they divided the patients into active and inactive disease, and I will say that I don't know what inactive FSGS was, and they never completely defined it, but they found that among controls, there were very few podocytes, inactive FSGS, very few, active FSGS, more podocytes, inactive lupus, almost none, pardon me, and active lupus nephritis were patients with the most podocytes in the urine. To summarize their findings, urinary podocytes were actually found alive in 75% of patients and also found alive in 100% of controls. So in other words, for each podocyte found, they were alive 3/4 of the time in patients and all the time in controls. Perhaps the most interesting finding was that diseased podocytes could actually be cultured from the urine more successfully, suggesting that the podocytes we were seeing from controls were actually senescent. And then 2 years later, Dr. Shanklin published a paper showing that podocytes detaching in experimental membranous nephropathy are actually viable and could be cultured. So if we do a little math, podocytes made up about less than 1% of the cytospin here. For those of you who aren't familiar, we have about 550 podocytes per glomerulus. So we start off life with about 550 million podocytes. If we take one of the disease patients who's losing 100 podocytes per milligram creatinine per day, they're literally losing 100,000 podocytes daily in disease. And by that virtue, all of your podocytes could be lost in 15 years of a severe disease state and half in 7.5, which is pretty scary. So if we fast forward, podocyte loss we know leads to glomerular sclerosis, and we can do podometrics, looking at the number, size, and density, and those can have prognostic utility. But how about urinary podometrics? Well, sadly for me, people have stopped looking for actual podocyte cell bodies and have moved on to looking at mRNA and protein for other podocyte markers. And I will say that it's quite challenging research. We looked at podocalixin when we saw the first slide, and it turns out that podocalixin is also detectable on the surfaces of endothelial cells and platelets and even parietal epithelial cells. So it's not as specific for podocytes as we originally thought. More often, folks who are studying podocyte proteins in the urine look at the mRNA and protein for these, nephrin, CD2AP, podocin, and synaptopodin. And WT1 and GLEP1, specifically more often protein is looked at. Perhaps the most challenging aspect is that many of these podocyte markers are actually downregulated in disease states, making it difficult to correlate how they might be important. When I spoke to Dr. Shanklin, who wasn't able to attend the talk, he did confirm that there's currently no gold standard for identifying whole podocytes in the urine, but he currently is working on a grant to do so. But we've certainly learned a lot from podocyte mRNA, and I'm just going to point out before we go on to the next question that we've learned that podocyte mRNA can be detectable in the urine of patients of diabetic kidney disease, and this can be true even before the onset of microalbuminuria, so giving us hope that we may have even earlier markers to diagnose diabetic kidney disease. Podocyturia has been found to precede albuminuria in preeclampsia. Podocyturia's increase in Fabry's disease correlates with the degree of histologic damage in IgA nephropathy. And podocin-nephrin mRNA may correlate with cardiovascular disease risk, which is not surprising given that it can herald the onset of albuminuria. So let's move from the bench over to the bedside and ask my next question, which is, do you need to have pyuria to have a diagnosis of AIN? And I think that, that we know the answer to this question, but nevertheless, let's just take us through a little history here. So we used to look at eosinophils in the urine. And this is a Hansel stain. We used to let the urine dry in the lab, and you could do this stain. It took hours. It was really a pain. But this is a picture of a beautiful eosinophil cast with some Hansel stain positive cells on the side. And everyone used to send urine for eosinophils. So in the early 2000s, that was part of the regular AKI workup. And gradually, people started to realize that the presence of eosinophils in the urine was not particularly helpful to distinguish a diagnosis of AIN. And perhaps this paper by Murathi and C. Jazz in 2013 put eosinophils to bed. He looked at 566 kidney biopsies, all with urine eosinophils tested contemporaneously with the biopsy. This is on the side, the number of biopsies with a specific diagnosis, and then in white, less than 1% urinary EOs, in gray, 1 to 5%, and in black, greater than 5%. And you can see that for AIN, the majority of cases of AIN, which they had biopsy proven, did not actually have any urinary eosinophils. Urinary eosinophils could be seen almost as often in patients with proliferative GN, with crescentic GN, and even in ATN, there were a fair number with greater than 5% urinary eosinophils. And as you know, we no longer even have the test for urinary eosinophils available. So AIN, I would argue, is one of the most challenging diagnoses to make clinically. Pirozzella put together a paper in 2019 putting together many, many cases of AIN and looking first at clinical presentations. He found that fever was present in 15 to 36% of cases, rash in a minority, eosinophilia in the blood in a minority, the triad of fever, rash, and eosinophilia in only 10% of cases, and oliguria about half the time. And then looking at urine diagnostics, there were about 194 urines available from all the patients with AIN in his study. And if we look and see what they found proteinuria present in 90% of cases, but this was generally below the nephrotic range. Interestingly, hematuria was present in half the cases. I always tell the students that we teach them that hematuria is GN and pyuria is AIN, and that's really not the case. There's a tremendous amount of overlap. And among these 200 urines, pyuria was present in about 50 to 80% of cases, depending on the study. What about white cell casts? They're pretty uncommon, only 3 to 14% of cases. Red cell casts were present in up to 29%. Granular casts, actually very common, 86%, which makes sense when we're hurting the tubular interstitial compartment. And notably, up to 1/5 of cases of AIN had completely bland urine sediment, which didn't surprise me because how often do you get called by the pathologist who tells you your patient has a whopping AIN and you never suspected it? Urine eosinophils, again, low sensitivity, low specificity, also present in ATN and GN, and urine chemistries could be any which way. Well, do not despair because we are moving into the period of biomarkers, and hopefully eventually we will have biomarkers to help distinguish these diseases. In JCI in 2023, a paper came out entitled Identification and Validation of Urinary CXCL9 as a Biomarker for Diagnosis of Acute Interstitial Nephritis. CXCL9 is a gamma interferon-induced chemotaxis agent, which pulls in white blood cells. And what they found, looking at many protein markers in the urine, against a large number of patients with biopsy-proven AIN, was that CXCL9 was 8 times in concentration higher among patients with interstitial nephritis than among patients with other kidney diseases. And they took patients with a biopsy-confirmed diagnosis of AIN. They initially tested CXCL9 on its discovery cohort at Yale, and they used several validation cohorts and subsequently looked at mRNA tissue expression. This was the initial graph that I showed you. It was a highly multiplex proteomic study looking at all different urinary proteins, and pulling out CXCL9 is by far the most commonly increased in AIN. They validated it and found an area under the curve of 0.94. And they also find higher mRNA expression in those with AIN. And so the paper concluded that urine CXCL9 is a good diagnostic biomarker of AIN. And I'm hoping that it becomes available soon. So what about the urine sediment and ATN? So how much can the urine help us? And in particular, I've always wondered if there's dense ATN, as we say, a lot of granular CAS, does it mean the patient's going to do poorly? So does the urine sediment predict outcome in ATN? And I'm going to say true or false, a patient with dense ATN is more likely to end up needing dialysis than a patient with rare granular CAS. This is what I call harbor view urine. It's packed with ATN. Really, there's only one study looking at this. That's a pretty good study from 2010, again, from Mark Parizella at Yale. He looked at 249 consults for acute kidney injury. And they set up a scale plotting basically granular CAS per low power field against renal tubular per high power field. And they did a scoring system of 0, 1, or 2, depending on how many renal tubular epithelial cells up to greater than 6 and how many granular CAS. So the most points you could have was 4. And this is what they found. So it's a pretty good graded increase in both the risk for dialysis alone, shown in purple, dialysis or death, shown in pink, and a higher AKIN stage or dialysis, shown here in yellow. So the more points you had, the worse that you were going to do. And I would say that overall, this is true, that a patient with dense ATN is more likely to end up needing dialysis than a patient with rare granular CAS. For the purposes of this talk, I won't get into biomarkers of tubular injury, but hopefully those will be out in the future and have better predictive value. But for now, again, I think looking at the urine is tremendously important for both diagnosis and prognosis. Daniel, I am actually over time, so I'm going to save this discussion of crystals in the urine until we give another talk on urine. I want to just close by showing just a couple of pictures. This is actually a picture that's not a great photo. It was taken from a patient in clinic recently who came in for a CKD evaluation. She had calcium oxalate crystals, but I think what was the nicest thing was that this is actually a cast filled with little calcium oxalate crystals. So it's a calcium oxalate cast. And notably, it was in a patient who we had absolutely no suspicion could have oxaluria or oxalosis. And I'm going to skip here. Just to tell you that urine is also now being tested for detecting cancer. Most recently, and unfortunately this was prior to the Trump administration, but the Department of Health and Human Services wanted to support biomedical health and breakthrough, announced in 10/2024 its goal to develop at-home self-screening tests that can detect 30 cancers using urine and breath samples. Right here, the FDA has approved bladder and prostate testing for urine cancer, and all these other cancers are currently being looked at in terms of whether we can detect them by looking at the urine. So yet another role for our wonderful body fluid. So in the last couple of minutes, if we have any, I'm wondering if anyone else has any questions for the urine.
Any questions out there? Thank you, Leah. Really a full, all-encompassing talk. Covered a lot of information in a short time period. Thank you.
Sure.
Ben, did you have a, oh, sorry. I saw you. Ben, you didn't have a question, did you?
I did have a comment actually. Leah, thank you for an excellent talk. It was really wonderful, and I'm glad to see that there are other enthusiasts for uroscopy, or I'm going to start calling it uromancy now in clinical practice. When you were talking about how the lab uses the computer to detect different findings in the specimen, do you think that there's any applications for AI in the future to potentially improve, hopefully, their detection rates, or is that something they're looking at already? I just don't know.
No, that yes, and actually there is a recent paper on how AI is going to transform urinalysis, which I just found pretty depressing to be honest. So, I mean, I think it's inevitable that we start seeing that, but until we actually have machines that can do it as well as we can, I still think we need to be looking. So. I was surprised at how poor the particle recognition was, to be honest, given where we are right now. It's really quite poor. So.
All right. And then Lily, I see you have your hand raised.
Yeah, thank you, Leah. I've definitely learned my love for urine through you. And this talk was really lovely, and I learned so much. My question might be a little tangential, but the fellows were talking about this over the weekend. So general medicine people are expected to know some urine sediments, like it's on their boards, and we like residents review it all the time. Although, as we know, most of them don't spin urine. Like how what would be your expectation for the journal medicine folks to be able to like what are like basic things that you think general medicine folks need to be able to identify, and how can we like kind of help facilitate that when nephrology is not like a required rotation for residents?
I think that that's an excellent question. I think for residents rotating through and students rotating through, I always include a little lesson on the most important crystals for them to know. For instance, they have to be able to recognize calcium oxalate crystals in the urine. It might be helpful for them to recognize acyclovir crystals. I give them just maybe 2 or 3 crystals. I remember when I took my first medicine boards in 1993, they actually had sulfadiazine crystals. It was an HIV patient with toxoplasmosis. Now we almost never see toxoplasmosis, so I don't think that we can expect internists to recognize sulfadiazine crystals. But I think there's sort of I give them the sort of 3 crystals they have to know about. I think that they ought to be able to recognize, a red cell cast versus a granular cast, and certain cellular elements. Beyond that, I don't think it's terribly important. We do, when we lecture to the medical students, we show them some typical crystals and some typical casts, but I think it's tough. I think most internists don't really have time to spin and look at urine or knowledge and experience in it. So.
I have a question, Daniel.
Yeah.
Yeah. Thank you, Leah. It's nice to hear from you to review the importance of the urine analysis. I have a question about the association between the quantification of granular cast numbers and the ATM prognosis. I'm thinking maybe it also depends on the timing. When did you do the urine analysis? Sometimes when we spin the urine, the patient already had ATM for a couple of days. And when you look at the urine, there are not many granular cast. I think based on my limited experience at Harborview, I feel sometimes you barely see some granular cast, but patients, we still think a patient had ATN, and also the patient was on dialysis for a long time. I think it's also maybe the tubular cells already fell off, all those casts already flushed out.
Right. Right. I think we impute all kinds of meaning to what we're seeing in terms of the number of granular casts. We've also, recognized septic AKI as a situation where we don't necessarily see granular casts, and yet the risk for dialysis can be very high depending on the septic milieu. And so I think that in the study that Parizella did was very focused on ATN patients and patients that they felt really comfortable had a clinical diagnosis of ATN, so rather than septic AKI or other things. But I do agree, and in that study, they looked early on in the first couple of days of the consultation. But it's very true. I mean, sometimes we get called while somebody's recovering, and sometimes at the beginning, sometimes while they're recovering is when they open up and start to actually pee and have casts in the urine when they didn't at the beginning. So it's a very good point, and I didn't mean to suggest that we could make we could just base our prognosis specifically on the urinalysis, but in general, it's suggestive of more tubular injury and higher risk. So.
Thank you.
All right. Well, thank you so much, everyone. And thank you so much, Leah, for finishing us off very strong.